you.
Vivek.
So somebody's typing away furiously.
Sorry, you're muted.
Can you hear me now?
Yes, yes,
Perfect.
thank you.
Thank you very much. So for those of you who missed the presentation 2 weeks ago, I'll have just 2 or 3 slides to recap on the polycystic ovarian syndrome, insulin resistance, but today we'll go into case studies. So some of the case studies I've got from you guys are not really related to this topic. I got somebody's request for patient with psoriasis having difficulty in losing weight. So maybe we'll tackle that when we do the weight loss one. And then there's a doctor who sent her husband's blood results. Lots of issues there, but wasn't related at all to insulin resistance or prediabetes. So I'll park those aside. And if you guys got any interesting cases for this topic, please interject. And then I rather do some of your case studies than my case studies because it always makes it more interesting and a bit more live. So Leonie's reminded me to tell you guys that that's her telephone number on the bottom right, and that's her email if you guys need to get hold of her. And so try to. So these are my disclosures. And this was the first slide we tackled the last time. So the basis of all of our discussion today is insulin resistance. And We spoke and we touched about how genetics play a role with insulin resistance, how the fetal environment plays an important role as well. So if mom had hyperglycemia, overweight, um, there's a higher risk of all the metabolic conditions to the child later in the life. And then, of course, the undernutrition theory as well will contribute towards insulin resistance. We know certain ethnic groups are at a higher risk of insulin resistance. Be that as it may, that if untreated will lead to prediabetes in 85% of people who are insulin resistant and overweight, and that will finally get to type 2 diabetes as well. The ones who are insulin resistant, that 15% who tend never to become diabetic because their beta cells can just keep pushing up enough insulin, they will still be overweight. And then, of course, we spoke about the importance of the beta cell and its function, and that will vary from person to person as well. We spoke about uh, what happens to fasting insulin and glucose levels. So if we look on the top, this is sugar levels. If we look over here, we're looking at insulin response from the beta cell. And what happens if you follow the yellow, initially as somebody becomes insulin resistant, the beta cells will compensate by producing a lot more insulin. And at some point, that individual's beta cells will become exhausted, uh, not able to push out enough insulin, and the insulin will drop away. And that's typically what we see in somebody who's type 2 diabetic, eventually requiring insulin. So from this point, as the insulin level drops, you'll see that the glucose levels are going to have to go up because there's no insulin to allow the glucose to be absorbed into the tissues. The gray shows the 15% of people who will remain insulin resistant for life and won't really develop type 2 diabetes. The bulk of us will. What was important is to note that here there's already evidence that macrovascular complications start way before the onset of type 2 diabetes, which is what this line represents. Whereas microvascular complication, there's an inflection point once you get an HbA1c above 7 over a period of time that will lead to microvascular complications. We touched on looking at some of the clinical signs of insulin resistance, the dorsocervical hump, classic. Just today, I was showing a patient, obviously because they can't see it. So I got them to touch my neck. And if you touch your fat pad over here, the distance between your finger and the bone, the spinous process from that particular vertebra will be about 2 or 3 millimeters in most people. However, here you'll have an accumulation of fat, and that is driven by insulin resistance. This is an extreme case, but your patients will have a much subtler picture where it's just velvety. It may just be hyperpigmented, and that and skin tags all represent insulin resistance. So you can pick them up quite quickly clinically. And what I find is our adult patients, when I show them this, they'll invariably come back, some of them, and say, oh, but my kid's already got that, and my kid's only 14 or 15 or 18 or whatever. And so you can start managing the next generation earlier before it becomes a problem. Euglycemic clamp is the best way to diagnose insulin resistance. It's only done in clinical trials, and not even in clinical trials, mainly laboratory testing. We use the Homer index with those clinical features. What happens if you don't manage insulin resistance? You can become that 15% where you just remain insulin resistant, overweight, and have macrovascular complications. The rest will develop in diabetes at some point, but before we get there, some females will be at risk of polycystic ovarian syndrome. Everybody will eventually have a weight issue. Insulin resistance and problems with the gut microbiome are the two causes I know of that can cause fatty liver. Consequences of prediabetes and type 2 diabetes. Eventually, we get the whole metabolic syndrome that has underlying cardiovascular sequelae. And then the theme behind all of this is low-grade inflammation. And then we touched on the treatment, and we can come back to that. But there are natural products on the left and some of the off-label use of pharmacological products, and we'll put that into context today. So let's start. Case 1. This is a 43-year-old female who came to me, and we diagnosed insulin resistance and an estrogen dominant state. From our previous webinars, estrogen dominance is at any point where the estrogen levels are much higher than progesterone can balance, or the estrogen levels are fine, but the progesterone levels are low. The body picks it up as a relative imbalance, and that contributes towards breast tenderness, water retention, mood swings before the cycle. They can have breakouts in the T-zone just before the cycle. These patients tend to put on weight. They got a term for it, the middle spread. And these patients are at a higher risk of fibroids, endometriosis, first trimester miscarriages, fibroadenomatous breasts, and then, of course, higher risk of breast cancer. So, if you look at this patient, let's start here in 2019. Most of the time, you'll see most of my bloods are done early in the morning. I tend to do them between 6 and 9. I do all of my tests fasting. And you can see this patient was highly estrogen dominant. So nowhere in the cycle is a level of 800 going to be normal. And some people may argue, well, what about ovulation? Yeah, but then during ovulation, your progesterone is meant to be much higher. So the ratios are completely off. And typically, I told you guys, in the first half of the cycle, the estrogen progesterone ratios, just take the Lancet laboratory results, forget the pico and the nanomoles. Just as you look at those numbers, this is meant to be 1/20th in the first 14 days, or the progesterone in the second 14 days of the cycle should be 1/10th. In other words, for any phase of the cycle, if you got an 800, that should be anywhere between 40 and 80. So can you see the ratio is completely off? So we put this patient on estrogen balance, and estrogen balance gets the receptor function to work better, and the estradiol levels drop. And then, not in all, but in most patients, the progesterone will go up as well. And you can see that the ratios about 6 months later looking much better. Fast forward to last year, August, looking stable without the need to use a contraceptive or synthetic estrogen blockers. But those days will come because she's only 43. And remember, in the 40s, estrogen dominance, if you're estrogen dominant, the estrogen progesterone ratios are just going to keep getting worse. Why? Because you and I cannot get rid of the environmental estrogens for these clients. And so from that perspective, they'll keep absorbing it. So you've got two sources of estrogen, their own, and in the 40s, they're pumping out much more, and you still got the xenoestrogens. And then what happens is the progesterone levels start dropping in the 40s, and that's what causes that imbalance. Now, today's theme is about insulin resistance. So if you look, this client had a high HOMA index, and the fasting insulin was 14.8, and we normally want it between 3 and 5. And so you can see over a period of time with treatment, the ratios improved, but the nature of insulin resistance is such that sometimes the patient cannot keep up with the treatment or the lifestyle changes, and it will fluctuate. And it's something that needs to be managed. So what did we do for this patient? So the estrogen dominance also feeds into the insulin resistance. So that's why I'm always tempted to manage it. So if you look at the calcium deglutarate in this product, most of my patients need to take 2. I started them off with 1 tablet a day. And as time goes on, we told you the estrogen dominance worsens. We may need to go up to 2, but that's 100 milligrams. And that decreases the conversion of the estrogen that is entered into the gut via the bile, via the gallbladder, and this gets metabolized by the bacteria and then gets reabsorbed, and it's the wrong estrogen metabolite. It's estrone. And so calcium deglutarate prevents or delays that from happening. Indole 3-carbinol, one tablet will give you 50 milligrams. We only really need 100 milligrams, even in the extreme cases. So between the I3C and DIM, again, we get a decrease in conversion of estradiol to estrone. And then even if there is estrone production, we move away from the cancer-forming estrones, which is the 4-hydroxy and the 16-hydroxy. And then sulfasalazine, you know, this the products that come from broccoli and some of the other herbs. We've got very high doses of all three herbs, and that is probably about 1.5 to 2 times the amount you're going to be finding in CellSure. So here, the treatment we used was estrogen balance, and for insulin resistance, I advocate to all my clients, slowly, they're going to build up to 10,000 steps a day. They avoid high GI carbs for 6 days of the week. So they're allowed to cheat 1 day of the week. They can do whatever the hell they like. But the other 6 days, typically they need to avoid the high GI carbs. And if they are going to eat the low GI carbs, they must always pair it with a protein. So a carb should never go unattended. That's the way I put it. And then in this particular patient, the fasting insulin, the HOMA index was not too bad. They were a bit reluctant to go on to something synthetic. So we went on to glucose stabilizer. I think I touched on this on the previous webinar. And glucose stabilizer has 6. So when this product was developed, berberine wasn't on the market. This product, I mean, we were using it from the time I was in Melrose Arch, and we at our new premises for 13 years now. And so this is probably about a 15-year-old product. And basically it has chromium, around 200 micrograms for every 2 capsules. So you can use up to 4 capsules. You got 3 grams of cinnamon. It's got HCA, which basically is an extract from West African mango, the plant, and helps with insulin resistance. It also decreases the glucose excursion. So instead of having peaks, it spreads it out a bit. It's also got menaguargam, which does the same thing, almost like the synthetic drug acapos. It's also got bitter melon karela, 500 milligrams. This is an Indian herb, an extract from a fruit, and basically improves insulin resistance. And then it's got D-inositol, a favorite amongst gynecologists and obstetricians, especially for insulin resistance. And then it's got high doses of that. So we've been using this D-inositol from around 15 years ago. And so this has all of it. And so based on how bad the insulin resistance is, you can use 1 before a meal or 2 before a meal and a maximum of 4. So we normally split it, 2 in the morning, 2 in the evening, or 2 in the morning, 2 in the lunch, and so forth. But basically, it has all 6 items in one. So that's what we did for that patient. Let me just go back, and you can see that the insulin levels did improve, and then the patient takes their foot off the accelerator and goes up again. And anyway, it's something that needs to be managed on an ongoing basis. So let's go on to polycystic ovarian syndrome then. So we define this by having 2 out of those 3 features. So these clients can complain about cycle irregularities, and it can finally lead on to complete amenorrhea. They may have features of hyperandrogenism. This may be clinical or laboratory evidence thereof. And then you will have polycystic ovaries as well, where you've got multiple cysts, and they're all arrested basically. So you only need 2 out of the 3. And I'm just going to touch on this slide. I didn't show you guys this slide, but found it later. And again, the theme is insulin resistance. And basically, what happens is if you look at these female patients' hypothalamus, they were normally supposed to have GnRH secreted in pulsatile fashion. So what happens is during the day, if you just follow this cursor, that's what you're going to be seeing, up and down movements in GnRH. And it's the pulsatile fashion of the way GnRH is secreted that you have a trophic effect, a stimulatory effect on the pituitary. So how can I be so sure? I just qualified in endocrinology in about 2000. In 2002, I was fortunate enough to go to Boston for an endocrine course. And at that time, they were all excited in Harvard because they were running a program to see, just like you get your type 1 patients on an insulin pump, at that time, they put 20 patients on a pump to see if they can get them to become fertile. And so what happened was that pump was designed to secrete GnRH all the time, as opposed to the way you and I may use beta-HCG in pulsatile fashion to get somebody to be more fertile, right? And what they found at $20,000 per person per year, and at that time it was a lot of money. After 1 year, they realized the experiment failed because if you secrete GnRH constantly, you lose the trophic effect. So it has to be pulsatile. And that's the basis of how contraceptives work. And we'll come back to why that is important. So it stimulates the pituitary, that then gets the LH, FSH to go up, and it gets the ovaries to make follicles. FSH, follicular stimulating hormone, LH will work on the hormones. Now, once you start losing that pulsatility, what happens is the FSH-LH ratios go in the opposite direction. LH goes up, and in the ovaries, you get these follicles, and the theca cells surrounding the follicles then secrete androgens. And if you've got lots of follicles, and then that means you've got lots of theca cells, you could have lots of androgens. And the androgens then, of course, cause downstream issues. But the main thing for the female patient is the hirsutism, excessive hair growth, upper lip, on the chin, around the nipple area, between the umbilical cord and the pubic hair. But generally, all around, they'll be a bit more hairy. They have acne. Typically, this is the male type of acne, where they will have it on the face, but also maybe on the arm, the chest, on the back. And then, of course, we spoke about the evidence of the insulin resistance, the acanthosis. And so that's the androgens. How do you get the atresia? So the atresia is basically, in order for a follicle to release an egg, it needs to move from not being existent to slowly increasing in size. And then once it gets to between 18 and 22 millimeters, the right follicle will then rupture and release the egg. And the problem here is that all of the follicles are stuck around the 8 to 12 millimeter mark. And they all then produce inhibin, and they prevent each other from progressing. And that's where you get the atresia. And then these patients tend to be a bit more overweight. We mentioned that. And you got more fat tissue. And in the wrong environment, the estradiol is going to be converted to estrone. And then, of course, that's not good. And then you can get endometrial hyperplasia as well, because what happens is you've got high estrogen levels, you don't have enough progesterone, and these patients don't bleed, and they're going to end up having a thicker lining. So that's the pathophysiology of polycystic ovarian syndrome. Now, it's important to understand this, because if we're going to treat it, then you need to treat the pathogenesis. And so what's the consequences of not treating PCOS? Infertility, obesity, hirsutism, acne, and more importantly, cardiovascular risk. So I touched on it the last time. I'm fortunate enough to see sometimes 2-3 generations in my practice. And so what happens is when the mum, who is in her 40s, is quite concerned about her weight, she's insulin resistant, and she sees that her child also has the acanthosis, they bring these kids in, and then I have the good fortune of doing these tests on these young kids, 14, 15, 16, 17, and they all insulin resistant. However, they all thin, as their mother was. And given time, they put on weight. So insulin resistance, in most cases, will precede the weight gain. Because in the past, 20 years ago, we used to tell our patients, you insulin resistant because you're obese. Now, I believe it's the other way around. And insulin is a growth hormone, and it's the one that drives the anabolic weight gain. And so how do we treat it? We touched on this. Lifestyle, very important. And so you'll see this in some of my patients, they end up taking marathon running and they manage their insulin resistance completely on lifestyle. Not many of us can do that, but that's proof that you can manage insulin resistance with lifestyle. And depending on how bad it is, you will have to vary your activity accordingly. Oral contraceptive pill, we're going to touch on that as well. So gynaes are big on oral contraceptive pills. Why? So if you go back to that pathway, what happens is you switch that axis off. So if you switch the hypothalamic axis off, yeah, and you take over the estrogen function at the level of the uterus, you make the lining, you give the progesterone with the combined contraceptive pill, and the patient bleeds. Because remember, these young girls are anxious. Not all of them want to be pregnant, but they want their cycles to be regular. And so from that perspective, the oral contraceptive pill does not fix the pathology, doesn't do anything to the insulin resistance, but switches this off, and you get exogenous estrogen and progesterone being given, and then you get a cycle, regular cycle. How does the contraceptive pill then help the hyperandrogenism? Because the hyperandrogenism was driven through this excess with the excessive LH and the theca cells. So remember, if you've now switched that excess off, there's no more cysts. So if there's no cysts, there's no theca cell lining. That means the androgens go down. And so just the way the oral contraceptive pill switches off the estrogen and progesterone excess here, you needed the same hormones to get androgen production, and now you switch that off. That's how the skin gets better. So the insulin resistance is still there, guys. And that's why when the client stops the oral contraceptive pill, you're back to square one eventually, 2 or 3 or 4 cycles later. And so in the short term, oral contraceptive pills are good. Psychological benefit to the client, they're getting a cycle, the skin gets better because the androgen's gone down, there's less hirsutism, and you're on your way. How you choose the pill is important, and we're going to touch on that. Metformin, now here you're addressing the insulin resistance. So metformin gets the liver to be less insulin resistant, so it takes up glucose more efficiently, stores it as glycogen. The metformin gets the fat cells to take up glucose more efficiently, and the muscle cells. And so if the glucose is cleared from the circulation, then there's less need for insulin on board, and that then sorts it out. And so metformin also has been shown in some work to improve ovulation. And then you can use clomiphene citrate. So how does that work? That's an analog that works at the level of the hypothalamus. And depending on the dose and type, you can act as an estrogen agonist or antagonist. And some of them work on a dual basis. So the true story is that nobody really knows 100% how clomiphene citrate works. We use it for fertility because it gets the client to make a lot more follicles. Anti-androgens, we're going to touch on all the different types, and then all the other things that can be used off-label. So let's talk about some of the drugs. We spoke about some of the natural products. They can act as anti-androgens, and the only real strong ones are beta-cytosterol and neem. That's an Indian herb, that's a South American herb, and incidentally, that's what the hair laser clinic uses. In terms of pharmacological, the pearl Androcur is an anti-androgen, finasteride, anti-androgen, and spirectin. So let's do a case study here. 29-year-old female, history of underactive thyroid. I'm not going to touch on that. We got that well controlled. Again, insulin resistance, but now we take one step forward, and this patient, as opposed to the last patient, had PCOS as well. And so if you look, don't all die of shock. Look at this patient's fasting glucose and insulin levels. So this is what I mean when you'll see some patients, they'll never turn diabetic. Look at that, 5.8, but with an insulin of 89. So this person keeps pumping out insulin and has not exhausted the beta cells. The problem is that, look at this HOMA index. That excess insulin is going to cause a lot of weight, a lot of fatty liver. And so that then needs to be managed. And so we've managed it through, I mean, that, if we look, is a period of about 6 months. And then, like I told you, this is always going to be a challenge. It's very difficult for these clients to keep, because I tell them, I said, look, you can go and do Atkins if you want to. You can go and do paleo if you want to. You can go and do whatever. All of those extreme diets will work for a short while, 3 months, 6 months, a year, 2 years. Eventually, you'll get heart fall. And so my default plan is always watch the high GI carbs, have a cheat day, feel human, get it out of your system. It's easier to keep that 6 days going. And so from that perspective, you got to keep that going till you're 84 years of age. And so look at this patient's journey, 89, 20, 12, 10, 6. And if you look from the beginning of this year, we started turning the corner. And so typically I'll want my clients to have a fasting insulin below 5 on 2 visits before I'm going to start stepping my support away. And the reason for that is I always tell them, one swallow don't make a summer. And if you can do something for 6 months, because they do my bloods on average 3 months apart, you know, when we're starting to get things looking well, then that means your 10,000 steps has already been ingrained, and that eating plan has already been ingrained if you can keep it going for about 6 months. And that's when we cut our support back. And so if you look at this particular patient, so I think I did mention that recently the new guidelines actually took away androstenedione as a test for PCOS, and they're doing this at their peril. Now, I don't know how many of you today, I can't even see how many people online here, because I can't see anything here today except the slide and this cursor. But here, look at the DHA. It's actually low. It's on the low end of normal. And so if you're just going to rely on testosterone, which is normal, look at the free testosterone index normal, and on DHEA to make the diagnosis of hyperandrogenism, you'll go wrong in some of these patients. So this patient's androstenedione levels were high, but these two were actually not bad. And in fact, because of the symptoms, and we're going to be covering adrenal fatigue, because of the symptoms this patient's gave me, the DHA cortisol ratios were actually off. So I actually gave this client DHA. And I know that this patient's going to take some of this DHA and convert it to androstenedione. So I had to treat the adrenal fatigue as well, and we discussed that they're going to be increasing it. It's not DHA that causes hair loss or acne. It's that client taking the DHA and pushing it through a different pathway towards dihydrotestosterone, and that's what drives the problem. So I blocked that pathway. I gave them the DHA, and eventually, as that adrenal starts improving and building up its reserve, you'll see they will overshoot. And when they overshoot, I aim for levels of between 3.5 and 4.5 in this particular patient. So they overshot, and then I reduced the dose, and they were still good, and then goes up again. I reduce the dose, and eventually you try and maintain it on the lowest possible dose to get you to between 3.5 and 4.5 in this patient, and eventually we'll able to get this patient off it. But this was just a lesson to show you that sometimes you will get features of hyperandrogenism, but there, DHA and the testosterone was always low. And so from that perspective, for this patient, the thyroid was well controlled, but the antibody levels were very high. So we gave this patient selenium, and we know that Google extracts, also plant extract from Asia, decreases antibodies, not only for Hashimoto's, but for lupus, rheumatoid arthritis, and alopecia, whatever. Now, I showed you that this patient had a fasting insulin of 89. That liver is going to suffer. So I use two products here to help with the insulin resistance. So NAC, N-acetylcysteine, is one of the strongest agents, and we've all used it. The guys who've worked in your internship, the doctors use NAC for paracetamol poisoning. Some of you guys have used it for nasal decongestion. So NAC, each capsule 375. Typically my patients need to use 2 liver balance, and that's one of the highest doses now, right? Because your Novartis product is 200 milligrams. It's a effervescent. I think Solal's 500, Metagenics is 600. So this is quite high, but you're getting the active selenium as well, which has been shown even in some big nutraceutical publications. Selenium has been shown to help the liver. Kudzo, alpha lipoic acid, dandelion extract, vitamin E. I mean, ideally you want 800, but you're not allowed to put that in South Africa. And so from that perspective, I gave this, but I knew that even 750 milligrams for this patient wasn't going to be enough. So I added extra NAC. That's what this NAC is there for. When you need it on its own, and you can dial up to 3,000 milligrams safely. So unless the patient's got reflux, because this can worsen reflux. It doesn't cause it, but if you've got reflux, it's going to definitely worsen it. So that's why I step it up slowly, and I tell them to take it after breakfast. So you're upright throughout the day and there'll be less reflux. But I had to use quite high doses. So for this patient then, we addressed the antibodies for the thyroid. We addressed the liver, and then 10,000 steps a day. Avoid high GI carbs. They allow the cheat day. And then here, you don't have to be a doctor to know you're not going to get that 89 down just with exercise, diet, and a natural product. So here we made a decision, and we decided to go off label, and we used metformin. Now remember, metformin does not drop glucose levels. So although this patient, see, not diabetic, where the hell is this? Not diabetic, see? And it doesn't drop sugar levels. So when you are going to use your previously registered products for diabetes, as long as you're using an agent that's not going to drop the glucose, but it's going to work on the insulin resistance like metformin does, it's going to work. So here we gave the metformin for ovulation purposes. It helps with the insulin resistance, and maximum doses, we went for the slow release and 2,000 milligrams. It does cause nausea, bloating, loose stools in about 5% of patients. If it does so, it will last for a week or two and eventually passes. And so we also added an SGLT2. So for those of you who've dropped down dead now, I'm going to show you why that is safe, because SGLT2s don't drop glucose. They make you pee out the sugar. So the devil's out of the room straight away. And so we used a combination of these two, and I went for semaglutide. Off-label use for semaglutide. And remember, we've been involved in clinical trials for a long time with semaglutide. And so here, the patient was told it's all off-label. We started off 0.25 on a weekly basis, slowly built it up to 0.5, and none of these cause hypoglycemia. But here's the proof of the SGLT2s now. So here, the guys who came up with EMPA did a study looking at patients with type 2 diabetes, look at their baseline levels, look at the glucose in this diabetic. Of course, it's high, they're diabetic. And so you use the EMPA, the SGLT2, and the glucose level drops. Look what happened to the insulin levels in their clinical trial. The glucagon did not change, interestingly. So we know the SGLT2s are not doing anything to the alpha cells. And then look at this. Look what happened to the ketone bodies. The ketone bodies went up. What the hell are ketone bodies? That means the body is learning how to use fat as a source of fuel instead of glucose. That is very important. And so you'll say, well, this is obvious. We know that's why they've registered it as an anti-diabetic drug. But now look, in the non-diabetic, fasting glucose didn't change. But the insulin levels changed. And they started using more ketone bodies. So that is why I was quite confident to say, I'm not going to cause hypoglycemia in a non-diabetic patient by giving them this. And so you can see what happened with the insulin levels over a period of time. And then, okay, hold on. Now, as we get to a point where we are now, for the last 6 months, the fasting insulin's between 3 and 5. I give the patient an option then, and I said, right, choose one. We're going to start weaning off. Normally, when they come to me with that kind of results with the 89, they shit scared. They don't want to get off their support because they're doing well. I mean, this client lost tons of weight. The point is, you've got to tell them that it's been 6 months, they've done well, they've maintained it. Our only way of knowing whether we're going to be able to maintain this with lifestyle is by weaning off. So I get the client to choose whichever one they don't want. Sometimes they base it on cost, sometimes they base it on side effects or whatever. And so let's say with this patient, we decide, right, we're going to cut back on this expensive stuff. So we go from 0.5 to 0.25. 3 months later, don't rush it. If that fasting insulin is still below 5, you stop this guy. 3 months later, if it's still good, you stop this guy. 3 months later, if it's still so good, you halve this guy because you're on 2,000. And then typically, some of these patients are going to need something as maintenance. But Rome was not conquered overnight. So you've got to be patient with these guys. And this patient lost tons of weight, over half their body weight. What did we do from an anti-androgen perspective? Because I told you here, the DHA was actually low, so I contributed towards the production of androsten down. It was already high, but we needed to treat the other condition as well. So here, I used the Organic Remedies Hair, Nail, and Skin, which has neem and beta-cytosterol. It's got 500 milligrams of neem, and it's got 300 milligrams of beta-cytosterol, and it's got all the copper and silica and biotin and all the natural products for hair. Anyway, 2 a day, and I knew that that wasn't going to be enough to bring an androsten down level of 7 down, so we went finasteride. Now, finasteride is used and registered for patients with prostate cancer. So you warn your patient about it, because when they go to the pharmacy, that pharmacist is going to raise their eyebrow to say, why is a female on an anti-prostate cancer drug? This product has been registered in Europe as an anti-androgen. In America, only for prostate. So in Europe, for prostate and anti-androgen. So it works by decreasing 5-alpha reductase. That's the enzyme that converts good testosterone and DHEA to dihydrotestosterone, and it also decreases androstenedione down. So it comes in 5 milligram tablets, half 3 times a week, and then we adjust it according to that androstenedione down level and symptoms, the hair growth, the acne, and so forth. Now here, you guys will know this drug by another name, Propecia. Comes in a half a milligram and 1 milligram. Those doses, for most of my patients, ain't going to do shit. It's too low. Now let's take another case study here now. This is a 17-year-old female. These are tests the gynae had done historically. So full blood count looks fine. Very bad vitamin D. Iron levels were fine. You must always do ferritin levels as well. Very important to check what's happening with the iron stores. So not only what's in the blood, but stores are important as well. And then fasting glucose was normal in this patient. This was all the gynae tests. No thyroid pathology and no antibodies as well. So they were not going to develop a thyroid problem. And then estrogen dominance. It doesn't matter where you're in the cycle, your progesterone should never be 0. So the ratios are off. The gynae puts this patient on Diane. Estrogen gets switched off, progesterone gets switched off. At that visit, they look at prolactin. Gynaes like looking at prolactin as part of PCOS. And then the calciferol took the patient from 14 to 20. Calciferol once a week. Gynaes like that particular drug. What do you think happened to this patient? They put on weight. So the Diane, the estrogen levels were way too high. Although this person was estrogen dominant, they probably should have chosen a medium dose contraceptive. Anyway, the patient put on weight. And then the gynae decided, no, we're going to change it. So they moved from Diane to Clara. Now, all contraceptives were supposed to switch off estrogen. Here's proof. See? It switched it off. That's how a contraceptive is supposed to work. If you're on Clara and you haven't switched off, guess what? You got 2 sources of estrogen now. Clara and your own. That's more estrogen. That's going to put on weight. So that's the client who tells you on Zol. So you and I are going to get patients with pathology. You and I are not going to get patients who come to you and say, ma'am, I want an oral contraceptive pill. I'm sexually active. I'm 19. I don't want to fall pregnant. So the vast majority of females out there, and you can get the symptoms of estrogen dominance by asking questions. If they're not, be my guest. Start them on years plus. Solely, Clara. The ones who come to us got pathology. They're normally estrogen dominant. That's why they make their way to an endocrinologist or you guys. And so those drugs actually make them put on weight. So you must ask the patient, did you put on weight once you started this? Yes or no? Are you spotting on it? Spotting means you're bleeding when you're not supposed to bleed. And so how can you spot on a contraceptive? Because you're only supposed to bleed during the placebo. So if you're spotting, that means there's estrogen coming from somewhere else because the drug was designed not for you to bleed. So you got a fixed amount of estrogen, fixed amount of progesterone, and you move along the month. And then you take away the drug and you have withdrawal bleeding. So now if you're bleeding in the middle of the month, it's because estrogen went up. But how can the pill give you more? You see, it's a fixed dose. So that extra estrogen had to come from somewhere. And that means that person is estrogen dominant and that pearl was not strong enough to switch that axis. Now can you see why I showed you the importance of that axis? You need to switch that axis off. And so here, Clara made this patient spot and continue to make them put on weight. And then look, still a shitty vitamin D. Remember, there's a precursor, it's a pro-hormone, and it's required for a lot of other conditions. Now they're doing something right. Remember, these are not my results now. These are results that came from the gynae. And so, look, ferritin levels low. You want that to be a bit higher. So you're not anemic, but not enough for hair, not enough for good skin, not enough for nails, not enough for good energy. And then look at this androstenedione dial. Now, Clara is a low dose contraceptive. It's not going to be high enough. If it's not high enough to switch the person's estrogen off, how the hell is it going to bring the male hormone down? That's why how you choose contraceptives become important. And this person would have probably done well from this perspective and this perspective on you can carry on with Clara and try estrogen balance. And if it switches it off, you're fine. But if it doesn't, then you need to move on to the medium dose contraceptive, because that will then help the androgen come down as well. So this guy, I normally aim for levels of below 2.4. The insulin levels, HOMA index was fine, but look, the quickie index, and gynaes like the quickie index, was abnormal already. So here, you need to be managing this as well. And then look at this patient now. You remember the previous patient, the DHA was low. Testosterone was normal. And it was the androstenedione that was high, but I didn't show you guys that. Now look at this client. That is high, and the DHEA is not very high. And so how did DHEA, there's a mismatch here. Can you see that? And that's why every patient is different. Some are going to have more of that. Some are going to have more of that. And then, of course, we need magnesium to be good. And I want it at least above 2.2. So in this client, we change over to a daily vitamin D3. This patient happened to be Muslim, and so it was important. They didn't want any animal products in their stuff. I gave them magnesium as well. I needed to get the level above 2.2. Now, magnesium is very important in insulin resistance, extremely important. And so you want to get that right. This particular product has magnesium bound in the glycinate form, which is the best form. The 1/2 to this will be threonate. The 1/3 to this will be citrate, and the worst form will be carbonate. And so glycinate, the highest dose on the planet is 1,000 milligrams. And basically, this is a slow release formulation. And so that it allows the product to last longer in the body. And we manage the estrogen in this patient as well. It's got methionine. More importantly, there's some TMG as well. Now, this person and this person are related. They're sisters. I treat their parents as well, by the way. Both parents are insulin resistant. And so these are the results then from the gynae. Full blood count was fine. Good lipids. Look at this. Triglyceride. Excellent. 0.6. Anything below 1, that patient is eating like an angel. So glucose was fine. So I don't know what's going on in the doctor's mind, right? But at the time, these were the blood tests that were done. I'm just showing you what was done. And then on another visit, we can see that this person's a poor methylator. Anything above 6, you're not methylating too well. No real evidence of fatty liver. Typically, I don't want these above 20. So there wasn't an issue there. And then why somebody would choose to progesterone on their own, I don't know. But progesterone here. And then on another visit, progesterone 0. Vitamin D, not good. Ferritins, much better. Much better. And then look, they were sisters, 1 year apart. Both have high androstenedione levels. That's why they came with hyperandrogenism, polycystic ovarian syndrome, and insulin resistance. But look at the DHA in this client. This person is actually a pharmacist, becoming a pharmacist. And so I was stressed out at university. The other sister was in matric, less stressed out, but you saw the difference in the DHA here now. And so that's why each individual, even though they're bound by more or less similar genetics, because both parents insulin resistant, you can see their presentations are different. And that's why you've got to modulate your treatment accordingly. So I'm not going to be able to see you guys. I'm scared to go off the screen. You know me and tech, not good. But any suggestions? Don't be scared, guys. How would you treat this patient here? Any suggestions? So I told you the diagnosis already. The person is insulin resistant. The person is vitamin D deficient. Androstenedione levels were 5.7. The important thing is she did have features of hyperandrogenism, and the patient complained of tiredness in the morning, energy dips in the afternoon, cravings after 8 at night. She wasn't sexually active, so libido wasn't a big issue there. Any suggestions, guys? And homocysteine was 8.2. So we gave them homocysteine balance. I started off with just 1. And if I get it below 6, they carry on with 1. And if it's not, then I carry on with 2, because that way they got 1,000 milligrams of TMG. You can't go higher. The B12 in this product is already methylated, B6 in 2 different, folate in 2 different forms, in a methylated form, and B6. And then that's the best we can do. Here, we didn't have to work too much on the liver. She ate like an angel in terms of doing the blood test. So here you would want an estrogen progesterone ratios. If you're a purist, you're a gynae, you want to do it day 3 or day 21. If you know ratios, you just do it and you go by symptoms and the ratios and you try and balance it. The vitamin D, you need this level around at least 50. Because this patient's got insulin resistance, which is a metabolic issue, I aim for levels of around 60. If there was an autoimmune issue, around 70. If there was cancer, around 80. But here, you wanted at least 60. Iron was good. And then any suggestions in terms of anti-androgens. So again, you could try a natural product. You could go for finasteride. You can go, if there's a need for a contraceptive, you can go for a contraceptive, and you base the contraceptive on what the estrogen progesterone ratios are like. And then you will not use spirectin in a patient like this. Although it's an androgen, spirectin specifically drops DHA, and you don't want this DHA to go down a bit more. So where you use your anti-androgens and how also matters. So that's the difference between this patient and what you would do for this patient, because both of them will get vitamin D. Both of them, I mean, they needed estrogen balance. You would choose a contraceptive a bit better. That guy needs to go up. But in this sister, you needed to give iron, not necessary for an infusion. You could get away with an oral iron. And the iron tablets vary from 10 milligrams right up to 30 milligrams. And in some patients, the higher the dose, the more constipation. But then if you use a lower dose, it's going to take forever. Fine. You find a way. Now here, in this particular sister, you could use spirectin if you wanted to, because that can afford to come down a bit. And that can come down as well. Or you could just rely on the proper contraceptive pill and see what happens to this guy. And see what happens to this guy. So the contraceptive will more likely drop testosterone. Your finasteride is more likely to drop this guy. And your spirectin is more likely to drop this guy. So they're all anti-androgens, but they all have the effect slightly different. And that I've just picked up over the last 20 years. I can't point you to a textbook. Now, pre-diabetes, you'll see this is the shortest part of my presentation, because if I've already showed you that in some cases I'm prepared to use a pharmacological agent off-label for something like insulin resistance, then pre-diabetes is a no-brainer. And so the diabetes prevention study I showed you guys, was done in the UK, showed that with exercise and dietetic intervention, you will drop the weight. You will improve insulin resistance, but eventually it slowly catches up over the years. Metformin without exercise and diet worked and then maintains itself. And if you do nothing, that's what happens. And so it is with that that we painstakingly got metformin registered for pre-diabetic use in South Africa. These are the criteria. We went through them last time. I think there's 2 people left in South Africa that don't meet these criteria in terms of who you would test for. So they're saying, who do you test for diabetes or pre-diabetes? And so if you go through this, there's only 2 people in South Africa you don't test. And then there's more of the criteria. So for me, that's a no-brainer. I think I'm one of the biggest users of metformin, and I think I've mentioned it to you guys in the past. I'm also on it. So I don't know why I put this slide here, but there's the TMG, the methylation complex, there's the riboflavin, there's the folic acid, but there's the methylated folate, there's the B6, molybdenum, B12, there's the methylated form of B6. So I'm going to stop it there because I spoke too much the last time, and it's exactly an hour. So now I'm going to be brave enough to get off this thing and see what the questions are like. So any questions, guys? Come, there must be a lot. You know, nowadays I'm getting, Leonie walks into my office every day with about 3 or 4 emails that she prints out, questions from you guys. So if I don't get back to you on time, it's my fault. It's not Leonie's, because the next day it makes its way to my table and I get a WhatsApp sometimes as well. And so from that perspective, I know a lot of you guys have questions. If you're shy, you know, send it as an email, but it's important for you guys to make this interactive because others learn as well. So I see some comments. Comment on the role of low-fat diet, fruit to avoid sugar substitutes. Right. So fruits. So remember, fruit is a sugar. So sugar cane is where you get sugar, the normal one that we use. In fruit, you get fructose, and from milk, you get maltose. And so from that perspective, your fruits are also divided into high GI, intermediate GI, low GI. And so on the cheat day, they're allowed to eat whatever they want to. On the other days, I would tell them they can have a low GI fruit. And then I always tell them to have 3 or 6 almonds with it based on how much fruit they're snacking on. Ideally, you shouldn't use fruit as an in-between snack. Rather have it post-meal as your little sweetie. In terms of a low-fat diet, so on another day, I'll show you guys a slide. In 2003, this study was published where they showed you what a low-fat diet does, what a low-carb diet does, and it was similar. The problem with a low-fat diet in an insulin-resistant client is that it's useless. You're not helping the insulin resistance. The insulin resistance is not driven by fat. Insulin responds to glucose. And so low-fat diets may play a role in a few other cases. We may tackle it when we're dealing with the webinar on weight loss. So I have the good fortune of Kim, Dr. Samaritano, comes in and does live blood analysis for me at the practice. So it's easy for us to see who's not digesting proteins, who's having an issue digesting fat, who's having an issue digesting carbs. Your genetics, I'm afraid, doesn't do it fully. And so from that perspective, we know HOMA index, quickie index is a quick way of knowing, is this person sensitive to glucose? Is there a blood test to show whether they're sensitive to fatty foods? No, not yet. Where can we get organic remedies from? You must contact that company. I'll tell maybe Leonie to WhatsApp it to you guys. If a patient still has an elevated cholesterol, on cholesterol balance, can you increase it to 2 capsules daily? Yeah. So I have got a few patients where I've gone up. Remember, cholesterol balance has Reddy's rice, the equivalent of 400 milligrams. So it's the highest in the industry. It's got 10 milligrams of polycasinol and coenzyme Q10. And so very rarely did I have to go up to 2. So go up to 2 only if the LDL or the cholesterol HDL ratios are still above 4.1. If you've managed to get it below 4.1, you're good. Don't worry about the total. You're worried about the ratio between good and bad. And then typically, if the triglycerides are still high, that means there's room for improvement in the patient's diet. And then have a look at the liver as well, because if there's fatty liver, if you work on that, most of the time there isn't a need to increase it. But yeah, you can increase it. And then let me just see, I'm going to have to go up here a bit because there's some other questions. No sound. Thank you, Sister Anne. Can you give a patient thyroid balance for thyroid antibodies? Yeah, that's exactly where you use it. That's the indication. So when your thyroid antibodies are positive and high, even though the patient may be on Altroxin, on Euthyrox, on thyroid S, on thyroid support, these are all glandular extracts, some made by Idexis, some made by Fagron, some come from America, desiccated armor. None of them are addressing the antibodies. And so if you want to address the antibodies and you want to slow the attack down, then you use thyroid balance. And so use it for about 6 months and then repeat the antibodies and it should start going down. If it does carry on, if it doesn't stop, because that means no product's going to improve that patient's antibodies. Now, what is this question? Can you give patient thyroid balance for thyroid? Okay. Does saw palmetto also reduce 5? Yes, it does. It's very weak, and so does pingium, and so does lycopene, an extract from tomato extract. So those are all reducers of 5-alpha reductase, but they're much weaker. So 5-beta-cytosterol and neem would be the strongest. So remember, the kind of cases I get, the levels are quite high. You guys might be getting patients with androstenedione downs of 3.5. All right. Then you can just probably get away with that organic remedies product and get them to below 2.4. But typically, I mean, the highest androstenedione level I had was 30. And that was when the upper limit was 3.3. They've recently changed the upper limit to 7 because the kit is now a bit different. So please feel free to email us. I think that's Leonie. Comment on, see, I'm not very good at this thing here. Comment on the role of low fat. Yeah, okay, so we've tackled these questions. Any other questions, Guy? Oh, is there any links between depression and the endocrine system? Yeah. Yeah, no, definitely. So they've shown that obesity and type 2 diabetes highly correlated with the incidence of anxiety and depression. So in fact, it is now known that anywhere between 30 to 50% of your patients with type 2 diabetes are likely to have some form of depression. And we did that MMed study at Barra as well, but it was a copy study. It was shown in other populations in other parts of the world. So one of my MMed patients showed that as well. And then in terms of type 1 as well, that we've always known, higher risk of depression. It's not easy for these patients who are 14, 18 to be injecting themselves. Their friends are having parties, drinking, eating whatever the hell they like, and these guys having to inject themselves regularly. So the depression has always been higher in type 1s, but now it's been shown in type 2 as well. And then on my talk on obesity, I don't know if I've given this group a talk on obesity, but I've got a slide where I show what obesity does from a mechanical perspective, from a metabolic perspective, and then what it does neurologically and what it does to cancers as well. So definitely a link there. Can you please revisit the upper safe limit of chromium picotinate? Yeah. And so chromium, guys, chromium works because it helps insulin resistance. It helps the second messenger system pathway on the receptor. However, if you use too much chromium, and they've shown that above 600, you will increase the risk of beta cell tumors. And so from that perspective, here more is not better. And so once 200 microgram hasn't worked, remember, you're just trying to get the receptor to work a bit better. Insulin resistance happens at a multiple level. So there's no point in just working on one aspect and pumping it to death. And so typically, I say 200 to 400, and you don't want to go more than that. Okay, Nadia, please elaborate on the link between cortisol and DHA. So we're going to be doing adrenal fatigue, but I'll touch on that. DHEA, okay, pregnenolone is the grandmother molecule. It gets converted to DHA. Between pregnenolone and DHEA, you get various pathways, some leading to progesterone eventually, some leading to estrogen eventually, some leading to testosterone eventually, and some leading to cortisol eventually. Yeah. And so DHEA balances cortisol. Very important. And so what happens is you want that ratio to be good. So if cortisol is high, eventually DHEA is initially it goes up, but then it drops. And that's called the cortisol steal syndrome. Remember, it's about balance. So it's going in the wrong direction. And typically, they will then present. So somebody with a highish cortisol will complain of having lots of cravings, difficulty in losing weight, short-term memory not good, irritable, impatient, palpitation, anxieties, feeling of impending doom, insomnia, that kind of stuff. A low cortisol will cause energy dips in the afternoon. So a low DHA, low cortisol, but we're going to go through all of this a bit later. And the link between cortisol and low testosterone, yeah. Remember, I'll show you, I'll have to do this talk with that whole slide where you can see the different pathways. Then you can understand that if the cortisol is high, why would the progesterone drop then? Because it's you stealing the substrate, and instead of the enzyme pushing it towards progesterone, it's pushing it towards cortisol, and then cortisol goes up, and that's what drops progesterone. So these are very interesting questions, Nadia, and that one we're going to be tackling. Oh, I think I missed a question here on some sugary stuff. What is your thoughts on sugary-free soft drinks and the effects on insulin levels? I find many dietitians use this as an alternative. Okay, so good question, May. So here, it's like cigarette smoking and vaping. For those who can't kill the habit of smoking cold turkey, some people can and others can't. Let's not judge them. It's just difference in willpower, different in addiction level. The ones who can't, I tell them, we used to tell them to try Nicorettes, right? And they got these patches because the cigarette smoke has 200 things coming into it. Whereas nicotine is bad, but that's one item, 199 substances less. So just the same way we tell them, go on to Nicorette, go on to the patches, and slowly wean your way off, I tell my patients, go and vape if you need to. And then slowly decrease the frequency of the vape, decrease the concentration of the nicotine, and it's the lesser of the evil. They're both devils, but it's the lesser of the evil. So now, with the sugary drinks, it's the same story. In a patient who is insulin resistant, somebody who's polycystic, somebody who's got a fatty liver. We need to cut down on the unrefined carbs. So here we will tell them no soft drinks, but they're going to drink this shit. So I tell them, listen, if you're drinking 4 Cokes a day, go to Coke Light, go to sugar free. At least they get the taste. Keeping in mind, and we tell them that this is not completely innocent. It's the lesser of the evil. It's your path to becoming good. And they've shown that these sugar-free drinks affect the gut microbiome. And I think we're doing the talk on the gut microbiome in January. So, and then if you mess with the gut microbiome, it in itself influences fatty liver and weight. And so from that perspective, lesser of the evil, it's a good weaning program for your client until they get to a point where they don't. What's interesting, May, is that they've shown that even carbonated drinks, just putting, so your sparkling water will have an effect on the gut microbiome, and it's got nothing else. So lots of interesting work on the gut microbiome, and both of us know how tough is it to get some of our patients off these things. So yeah, I'm happy to use it as a weaning product. All right, so I think we've been going on for 1 hour, 15 minutes. What is your remedy of choice for high cortisol levels? Nadia, so stress damage control, stress less, ashwagandha. I've named it from the strongest to the weakest. Obviously, how you dose it is important as well, and we're going to be discussing this at the next visit, and at what point you need to stop, because if you drop the cortisol too low, it's a problem as well. And if you've got a low cortisol and you take it up too high, it's also a problem. Oh, Maxine, why would, oh, hi, Maxine. Maxine's from Dubai. Very clever exercise physiologist. Why would somebody who eats no carbs or sugar, has a high fat diet, is also very active and higher fasting insulin levels? Okay, and so very interesting question. So the question is, if somebody is having absolutely no carbs and no sugar, but is on a high fat diet, is very active, may still have higher fasting insulin levels. Remember, insulin resistance is an endocrine state, and it's genetically determined. Yes, there's environmental factors, but that patient who came with levels of 89, there's some, fortunately, you can see how long it took us to get that patient right. But sometimes you never get them right. But a 15 is better than an 89. A 7 is better than a 30. So sometimes you never get these patients right. So there are patients where I get them right just on glucophage. There's some patients I get them right just on exercise. And some patients, I've got them on the same treatment I would have a diabetic patient on, and they still not sorting their insulin resistance out. And that's what we see at a genetic level. Remember, if your client is a female, has features of hyperandrogenism as well, you might want to exclude adult onset congenital adrenal hyperplasia. So that's by looking at a test called 17-hydroxyprogesterone. This, you want to do it in the second half of the cycle, and typically levels above 8, refer that patient to an endocrinologist. And so a very interesting question, but as long as the person is not having hidden carbs and sugar levels, we just need to manage that insulin levels. And I think, Maxine, I know who you're talking about. So that person must still keep avoiding the carbs. All right. Good night, guys. So maybe send me cases that are specific to the topics that are coming up. And then the 2 doctors that have given me the case studies, the one with the husband and the doctor with the psoriasis. The doctor with the psoriasis case, we'll discuss it when we're discussing obesity. The other doctor's husband, that's, I think you and I are going to have to chat over the phone, because it's not fitting into any of the pure topics that we're currently talking about, and it's very multifactorial. So with that, I bid you guys good night. Thank you guys for attending, and we'll see you guys next time. Thank you.